All right, we're going to do rheumatology now. Let's start with the first case. A 35-year-old woman has had joint pain and swelling for 1 year. The pain began in her right knee, left elbow, and right wrist, and now has become bilateral and involves the metacarpophalangeal joints. She has not had any pain or swelling that involved the distal interphalangeal joints. All right, let's stop there. Why is that important? Why is that important? The pain that she's having, the arthritis that this 35-year-old female is having, is in her metacarpophalangeal joints, but not in the distal interphalangeal joints. Why is that important? So how does that help you in your differential diagnosis? Okay. So basically, in rheumatology, the most important thing, or one of the most important things to consider in actually making a diagnosis of an arthritis or whatever connective tissue disease that you're talking about, is to understand the joint pattern and what the importance of the joint pattern is making the diagnosis. There's a difference between arthritis involving the distal interphalangeal joint and arthritis involving the proximal interphalangeal joints and the metacarpophalangeal joints. And what's that difference? What causes distal interphalangeal arthritis? Osteoarthritis. And what else? Psoriasis, right? So it's very easy. So if you have distal interphalangeal joint involvement and arthritis, you know that you're dealing either with psoriatic arthritis or with osteoarthritis. If the involvement is more proximal, the proximal interphalangeal joints, the metacarpophalangeal joints, then you know that you're dealing with either rheumatoid arthritis or SLE, or one more thing, one major thing that can actually cause a symmetrical arthropathy. Systemic sclerosis, more classically viral arthropathies. So things like parvovirus B19, hepatitis B, hepatitis C, those kind of things can give you a viral arthropathy that is similar to rheumatoid arthritis, similar to SLE, but different in a way that we're going to discuss in a moment. All right? So just looking at this history, and you see the pain began in her right knee, left elbow, right wrist, but has now become bilateral and symmetric, involving proximal joints. That's actually a typical history for either rheumatoid arthritis or systemic lupus. So let's go on. She has morning stiffness that lasts for approximately 2 hours. Why is that important? Why is that important? Do patients with osteoporosis get morning stiffness? They do? What? They do, right? They get morning stiffness. So what's the difference between the morning stiffness of osteoarthritis and the morning stiffness of rheumatoid arthritis or systemic lupus? The duration. Okay, so what about the duration? Okay, so in osteoarthritis, the morning stiffness actually lasts less than a half an hour. But when you have inflammation, when you have joint inflammation, you're talking about morning stiffness that lasts greater than 30 minutes. So patients who have ankylosing spondylitis, patients who have rheumatoid arthritis, patients who have systemic lupus with arthritis will have morning stiffness, but the morning stiffness will be greater than a half an hour. Patients with osteoarthritis won't have morning stiffness, will have morning stiffness, but it'll last less than a half an hour. And what's the difference between all these diseases on one side? Rheumatoid arthritis, SLE, seronegative spondyloarthropathies, and osteoarthritis? Inflammation. That in rheumatoid arthritis, you have an autoimmune process causing inflammation. In SLE, you have an autoimmune process causing inflammation. And in ankylosing spondylitis or your seronegative spondyloarthropathies, you have inflammation. All right? So just by looking at the history, at the joint pattern, the duration of the morning stiffness, and the next kicker in rheumatology is what? What else do we look at? We look at joint pattern, We look at morning stiffness, but what else do we look at to help us differentiate between all these connective tissue diseases? Extra-articular manifestations. So you want to ask yourself 3 questions when you're dealing with a patient with arthritis. What's the joint pattern? Number 1. Number 2, is there evidence of inflammation or no inflammation? And number 3, are there extra-articular manifestations to the disease that directs me towards one particular diagnosis versus another particular diagnosis? And this is going to be a recurring theme when we go through these cases. We're going to be asking ourselves these questions, and hopefully we'll be coming to answers. How to differentiate rheumatoid arthritis from SLE. How to differentiate rheumatoid arthritis from viral arthropathy. How to differentiate SLE from ankylosing spondylitis. How do we make these differentiations? And we make these differentiations by answering these 3 questions. What is the joint pattern? Is there inflammation? Is it an inflammatory disorder or not? And what are the extra-articular manifestations of the disease? Okay. So let's go on. She has morning stiffness that lasts for approximately 2 hours. Patient also knows generalized fatigue and weakness. She has no rashes, hair loss, or back pain, and no history of fever, weight loss, or diarrhea. Why is the history of diarrhea important? Why is the history of diarrhea important? Inflammatory bowel disease. Thank you very much. So inflammatory bowel disease is actually one of those diseases, or the arthritis caused by inflammatory bowel disease is one of those arthritis considered to be a seronegative spondyloarthropathy. A seronegative spondyloarthropathy. There are 4. Psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, and Reiter syndrome. Those are the 4 seronegative spondyloarthropathies. Okay, so she has no diarrhea, so there's no evidence of any sort of inflammatory bowel causing her pain. Why the fact that there's no back pain is important? Why is that important? Okay, so patients with rheumatoid arthritis don't have back pain. The back is never involved. Like the distal joints are never involved, the lower back is never involved. You could have spinal involvement at the level of the cervical spine, but you never have lower lumbar spinal involvement in rheumatoid arthritis. So the fact that she's having no back pain, no diarrhea or weight loss. Now, why are the rashes, hair loss important? Why is that important? What does that help us differentiate? SLE, okay? So these are the extra-articular manifestations, right? So she's a lady who comes in basically no alopecia, no rash, with a symmetrical inflammatory proximal arthritis, which is chronic. And that's why the most likely diagnosis is rheumatoid arthritis. Rheumatoid arthritis. That's why the most likely diagnosis is rheumatoid arthritis. So you have to be able to you should be able to look at a history and have a basic idea of where you're holding in terms of what the diagnosis is in terms of rheumatologic problem. So let's go on to the physical exam. Her temperature is 37 degrees centigrade. There is active synovitis consisting of warmth, swelling, and tenderness of the knees, wrists, elbows, metacarpal phalangeal joints, proximal interphalangeal joints, and ankles symmetrically. This is a symmetric proximal arthropathy with evidence of inflammation. Distal interphalangeal joints are spared. There is a flexion contraction of the right elbow. There is no hair loss, oral ulcers, or rash. Now that's important. Why? SLE. Extra-articular manifestations of SLE. There's no hair loss, there's no alopecia, there's no rash, and there's no oral ulcers. Her lungs are clear, heart has no murmurs, rubs or gallops. Her abdomen is soft and non-tender with no hepatosplenomegaly. So, does everybody understand why this is rheumatoid arthritis? Why this is not SLE? Why this is not ankylosing spondylitis? Why this is not a viral arthropathy? Why isn't this a viral arthropathy? Why can't this be parvovirus B19 infection? Duration. What do you mean by duration? Right, the chronicity of the disease. Right. If you look at all of the criteria for the diagnosis of rheumatoid arthritis, it's joint stiffness greater than 6 weeks. This greater than 6 weeks. That greater than 6 weeks. So on, always greater, a lot of times greater than 6 weeks. In order to make the diagnosis of rheumatoid arthritis, you have to have a chronic disease. You don't have an acute disease. For viral arthropathy, the classic case they'll give you on the boards is a young woman who's 25 or 26 years old, who works in a nursery, who works in a kindergarten, who works with young children, who may or may not have a rash, presents with an arthropathy which is proximal and symmetric, just like rheumatoid arthritis, but lasting less than 6 weeks, or lasting for 3 weeks or for 2 weeks. And there, because you don't have this element of chronicity, it's difficult to make the diagnosis of rheumatoid arthritis. In fact, it's impossible to make the diagnosis of rheumatoid arthritis. So what differentiates rheumatoid arthritis from viral arthropathy? It's the onset. It's the time at which the disease occurs. So, we understand why the most likely diagnosis here is rheumatoid arthritis. Now, how do we treat rheumatoid arthritis? What's the first medication that you're going to give a patient with rheumatoid arthritis? Steroids? Non-steroidals. Okay. So you're going to give NSAIDs. And in fact, a lot of times when patients present with rheumatoid arthritis, the diagnosis is in question until the disease progresses or until the disease becomes manifest more obviously. So if you notice at the beginning of her presentation, she didn't have symmetric proximal arthritis. She didn't have the typical arthritis of rheumatoid arthritis, right? She had pain in her right knee, in her elbow, in her right wrist, and only later did it become bilateral, involving the proximal joints, and symmetrical, involving the proximal joints. So usually what will happen in rheumatoid arthritis is that you'll start the patient on NSAIDs, and then when the disease becomes manifest a month, 2 months down the road, then you will treat them for the rheumatoid arthritis. Then you will treat them for their rheumatoid arthritis. So, that begs the question, how do we treat rheumatoid arthritis? How do we treat rheumatoid arthritis? We give NSAIDs as the best initial therapy. In this situation. But what other medications can we give to treat rheumatoid arthritis? Okay, DMARDs. What are DMARDs? Okay, disease-modifying anti-rheumatoid drugs, right? DMARDs. They modify the disease. Now, when do you want to start on disease-modifying anti-rheumatic therapy? Early in the disease course, late in the disease course. When do you want to start? Who votes for early? Who votes for late? Okay, the answer is early. In fact, the treatment of rheumatoid arthritis has undergone a paradigm shift in the last number of years. In the past, we used to treat with DMARDs sort of late in the disease. We didn't take it so seriously. But now, because we understand that most of the joint damage and most of the complications of rheumatoid arthritis, and the joint damage occurs within the first 2 years of the disease, if we can actively address and treat the disease early on, we may be able to prevent the development of a lot of the complications of rheumatoid arthritis later on. We have a 2-year window, essentially, to treat them. And if we take that opportunity, we can arrest the progression and reduce the complications and reduce the surgeries and reduce all of the ugly stuff that comes later on. So now, the shift is to treat much earlier. And the goal is to try to put the patient into remission, to make them as least symptomatic as possible. So what DMARDs do you know? Methotrexate. What else? Okay, hydroxychloroquine. What else? Gold. What else? Penicillamine. What else? Sulfasalazine. What else? TNF alpha. agonists like etanercept and infliximab. Okay? Now, if you remember infliximab, you use it also in inflammatory bowel disease. Right? So you can. And here's a second indication for infliximab in rheumatoid arthritis. Now, how do we treat rheumatoid arthritis? If they would ask you on the boards, this lady comes in and you want to start disease-modifying anti-rheumatic therapy, what is the drug of choice, the first DMARD of choice that you would use? Is it methotrexate? Is it sulfasalazine? Is it hydroxychloroquine? Is it gold? Is it penicillamine? Is it etanercept? And is it infliximab? What's the drug of first choice? Methotrexate. Methotrexate is the drug of first choice when you're starting DMARD therapy. Why? Because the time of onset, the time of onset is much shorter. It's 6 weeks rather than 6 months for most of the other DMARDs. So the time that the patient begins to feel better is much shorter than with the other ones, than with the other DMARDs. So you go with methotrexate. So the initial DMARD that you're going to use for the treatment of rheumatoid arthritis is methotrexate. Now what happens, what's wrong with methotrexate? Why do we not stop there? Why do we need etanercept and infliximab and leflunomide and hydroxychloroquine and sulfasalazine? Why do we need all of these medications? Why don't we just use methotrexate? Why don't we just use methotrexate? Well, because methotrexate is efficacious but does not completely eliminate the disease. So let's say a patient with rheumatoid arthritis has 30 joints involved. You give that patient methotrexate, and the patient now has 15 joints involved. They feel a lot better, but remember, the goal of our therapy is to try to make these patients as asymptomatic as possible, as quickly as possible, so their joints do not become damaged and they don't experience the complications of the disease. So the problem with methotrexate is that it is effective, but not completely effective, partially effective. And that's why we need to add these other DMARDs, other drugs that we use to treat rheumatoid arthritis. Now, what are the other drugs that we use? Now, let's say you give the patient methotrexate, and instead of having 30 joints involved, they now have 15 joints involved, and you want to give them something else. Okay? There are a number of choices that are all legitimate. Okay? Do not answer infliximab and etanercept right away. Because why? Those drugs are extremely expensive. And there are drugs that are as equally effective but less expensive in the treatment of rheumatoid arthritis. What are those drugs? Well, if the patient's on methotrexate, you can add hydroxychloroquine and sulfasalazine. You can add hydroxychloroquine and sulfasalazine to try to put them into remission. Alternatively, if the patient's on methotrexate, you can add leflunomide. And only after the patient has failed therapy with one of these combinations do you actually add on the infliximab or the etanercept. So the infliximab and the etanercept are extremely effective but expensive, and therefore we go with the leflunomide plus methotrexate or methotrexate plus hydroxychloroquine and sulfasalazine. Now, let's say this 35-year-old female has joint pain, she has a diagnosis of rheumatoid arthritis, and you start her on her NSAIDs, you start her on her methotrexate, and she responds to the methotrexate, and then you put her on the leflunomide. Now, she comes in and she says, doctor, I would like to become pregnant now. What is the drug that can be used to actually clear the leflunomide from her blood? What cholesterol-lowering drug can be used to clear the leflunomide from her blood? Cholestyramine, correct. Okay? And the reason for that is that the leflunomide is actually circulated through the bile into the liver 2/3 of the way, 2/3 of the time. 2/3 of it in the body. And it actually stays in the body for many, 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 many months. So you can give cholestyramine if they overdose on the leflunomide or if they want to become pregnant on the leflunomide. Now, what is the role of steroids in the treatment of rheumatoid arthritis? What's the role of steroids in the treatment of rheumatoid arthritis? Basically, symptomatic relief. Patients feel a lot better when they get their steroids. The problem with the steroids is that there's a lot of side effects like hyperglycemia, osteoporosis, cataracts, hypertension, easy bruising, and so on. So we don't like to keep these patients on steroids chronically. We do it sort of to get them over the hump of their exacerbation or whatever, or they get them over the hump of their acute arthritis. Any questions on rheumatoid? No. So let's go on to this. Okay, so here you see an X-ray. What is the diagnosis here? Okay. Well, there are two types of deformities in the fingers with rheumatoid arthritis, right? There's Boutonniere's deformity and there's swan neck deformity, right? So what's the difference between Boutonniere's and swan neck? Well, Boutonniere's is hyperflexion of the proximal joint with hyperextension of the distal joint. Swan neck is the opposite. Hyperextension of the proximal joint with hyperflexion of the distal. So I can't really do it because my fingers don't hyperextend, but this is Boutonniere's deformity on X-ray. Okay? What is this? Okay? This is actually ulnar deviation. You see the hands are splayed like this. This is ulnar deviation as a complication of rheumatoid arthritis. And what's this? It's a swan neck deformity. You see the hyperflexion of the distal joint with the extension of the proximal joint. What's this? Okay, so this is the cervical neck, the cervical spine in a patient with rheumatoid arthritis, right? Hyperextending or extending, and then flexion. And here the finding here is if you see how the spinal processes actually separate. This is cervical spinal instability in rheumatoid arthritis. All right, let's go on to the next case. A 50-year-old man seen in the clinic 2 days ago for community-acquired pneumonia comes to your clinic today with swelling of his left ankle joint. The swelling and pain of the ankle joint developed overnight. He denies any trauma. He has had similar attacks 6 months ago for which he took some over-the-counter painkillers. He never sought medical help, and the symptoms resolved spontaneously after a week or so. He denies any other significant past medical history and has not had recent sexual contact or trauma to the area. His temperature is 37 degrees centigrade, blood pressure is 120/85, and pulse is 88 beats per minute. Left ankle is swollen, warm, tender, and erythematous. Small effusion is present, and movement of the ankle is very painful. The other joints are normal. No skin rashes are noted. So what is the most likely diagnosis here? Okay, gout, good. And in what other, as soon as you say gout, another diagnosis should come out. What? No. You say gout, what else should come out in your mouth in the same thing, in the same sentence? Gout and septic arthritis. All right? So that's the basic differential diagnosis in a monoarthritis. This is an acute monoarthritis. This is a gentleman, basically. He's a 50-year-old man, seen 2 days ago for community-acquired pneumonia. He comes with swelling of his left ankle joint. Okay? It began overnight. This is not a chronic process. This is not a disease it's not an arthritis that he's been having for weeks and weeks and months and months and months. Yesterday he was fine, and today he comes in overnight with an acute monoarthritis. And the two major diagnoses to consider in acute monoarthritis are septic arthritis and gout, or some sort of crystal arthropathy, gout or pseudogout. Septic arthritis or gout. Now, what in the history points towards gout rather than septic arthritis? What? Somebody said it. A previous episode, right? Somebody doesn't have septic arthritis, generally doesn't go away by itself. So he's describing a previous episode of this arthritis, which was acute and monoarthritic, and that makes the diagnosis of gout a little bit more likely than septic arthritis. A little bit more likely than septic arthritis. Now, what's the best initial test in the diagnosis of this patient? What? Arthrocentesis, correct. So you're going to do an arthrocentesis. Why are you doing an arthrocentesis? Why? What are you looking for? Okay, so you're looking for evidence of septic arthritis versus crystal-induced arthropathy. And how do you differentiate between the two? You look at the cell count. You look for crystals. What about glucose? Do we look for glucose in the joint fluid? Is that important? Not really. It's really the cell count and the crystals. Are there crystals? And what's the cell count? So above what cell count above what cell count in the fluid is suggestive of septic arthritis? 50,000. So anything above 3,000 to 50,000 is inflammatory. And it could be rheumatoid arthritis, it could be SLE, it could be viral arthropathy, it could be ankylosing spondylitis. But above 50,000, suggestive of septic arthritis. So you're looking at the cell count and you're looking at the crystals. And what kind of crystals do you actually want to find in gout? Negatively birefringent crystals. All right? So you're looking at the crystals, you're looking at the cell count. And that's the best initial test to make the diagnosis in this particular case. So, you do the arthrocentesis, you get out the fluid, and you find crystals in this particular case. What is the best initial treatment or the best initial step in the management of this patient? Okay, are you going to give colchicine or are you going to give indomethacin? Okay, indomethacin you're going to give first. Okay? Then you're going to give colchicine for the acute attack. Are you going to give allopurinol? Why? So, I always thought that in gout, uric acid is bad, right? So why wouldn't I not want to give allopurinol for an acute attack? I'm lowering the uric acid, am I not? Okay, it precipitates the attack. But why does it precipitate the attack? Because actually, gout is not caused by the absolute level of the uric acid, more by fluctuations in the concentration of uric acid. So if you give allopurinol and you start fluctuating the levels of uric acid in the blood or in the serum, you will exacerbate the attack, even though you are lowering the levels of the uric acid. All right? So you don't give allopurinol for the acute attack. You give indomethacin and or you give colchicine for the acute attack. Allopurinol is reserved for prophylaxis. Now, when do we prophylax patients who come in with gout? They have recurrent attacks. What else is an indication for prophylaxis? Renal insufficiency, nephrolithiasis, and tophaceous gout. If they have tophi, they get prophylaxis. If they have renal insufficiency, if they have nephrolithiasis, if they have recurrent attacks, you prophylax them. Now, how do we prophylax? In fact, you can prophylax with colchicine. You can prophylax with gout with colchicine initially. And only after they fail do you go to allopurinol or do you go to the probenecid. Now, what's our goal in terms of our uric acid in the serum for prophylaxis? What's our goal? Less than 10, less than 7, less than 6, less than 5. In fact, less than 6 milligrams per deciliter. Now, if they have tophi, the tophi won't improve unless you have to go less than 5. All right? So our goal for prophylaxis is a uric acid level less than 6. And if they have tophi, less than 5. Now, what if they have... what's the difference basically between prophylaxing with allopurinol and probenecid? What's the difference? Okay, well, what will determine whether I give probenecid or allopurinol? You can actually measure the 24-hour uric acid, right? So if the 24-hour uric acid is greater than 800 milligrams, what am I going to give? What am I going to give? Allopurinol, because they're overproducers, right? They're producing a lot and the kidney's getting rid of a lot. If the 24-hour is less than 800 milligrams, under secretors, and they get probenecid, right? It's like this. Basically, if the urine cannot secrete out the uric acid, then there's a problem with the kidney. They're not secreting enough. And you give the probenecid to sort of kick the kidney in the butt to get the kidney to secrete out the uric acid. If the kidney is actually excreting all the uric acid that's there, they're just making too much. And you give the allopurinol to suppress the synthesis. So in summary, in acute monoarthritis, always consider crystal arthropathies and septic arthritis or septic joint. The best initial test is arthrocentesis. You're looking for crystals, you're looking for cells. Once you've made the diagnosis of gout, the best initial treatment is indomethacin and colchicine in the acute attack. You do not give allopurinol because fluctuations in the uric acid level in the serum can actually exacerbate the arthritis. For prophylaxis, you can use colchicine. If the patient has tophi, if the patient has renal insufficiency, uric acid stones, recurrent episodes of gouty arthritis, you prophylax. If they are overproducers, you give allopurinol. If they are under secretors, you give probenecid for prophylaxis. That is the basic algorithm. Let's go on to case 3. A 28-year-old woman comes to the office and states that for several months she has had intermittent joint pain, but only had discrete swelling of the joints recently. She points to her wrists and metacarpophalangeal and proximal interphalangeal joints. She also has suffered from intermittent fevers, morning stiffness for longer than 1 hour, and a weight loss of 15 pounds. Okay, so let's look at the joint pattern here. What is the joint pattern here? She has morning stiffness greater than 30 minutes. So already we know we're dealing with an inflammatory disorder, an inflammatory arthritis. Can't be osteoarthritis, because in osteoarthritis, no inflammation. And the morning stiffness is less than 30 minutes. All right? So she's had intermittent joint pain for several months, discrete swelling of the joints, which only happened recently, and she's pointing to her proximal joints. Her metacarpophalangeal joint and her proximal interphalangeal joint, which is suggestive of what? Either rheumatoid, SLE, or viral arthropathy. All right? Now, how are we going to differentiate between rheumatoid, SLE, and viral arthropathy? Well, we said viral arthropathy is acute. Is this acute? No, it's chronic. Can't be viral arthropathy. And how do we differentiate between rheumatoid arthritis and SLE? We're going to look at what? Extra-articular manifestations. So let's look here. So she has a proximal symmetrical arthropathy. She has intermittent fevers, morning stiffness for longer than 30 minutes, for 1 hour, and a weight loss of 15 pounds. She noted a rash on her face several months ago after being at the beach, which took 1 month to resolve. She expresses the concern that maybe it is all in my head. I feel like I'm going crazy. She denies a history of diarrhea, which is important to exclude a seronegative spondyloarthropathy, and there is no history of known insect bites. Her prior medical history is significant for 2 spontaneous abortions. So, what's the most likely diagnosis in this particular case? SLE. Why? Extra-articular manifestations. She's got the symmetrical proximal arthropathy with rash, with photosensitivity, and spontaneous abortions. Now, what are the 4 extra-articular manifestations that are actually unique to SLE? That if you have these, you know that it's SLE because they don't occur in rheumatoid arthritis. What? Well, there's actually, what does lupus mean? Does anybody know what lupus means? What's the name lupus erythematosus? Erythematosus. Yeah, it's the butterfly rash. And what does lupus mean in Latin? Wolf-like, right? So wolves are dogs, right? They're part of the canine family. And what do dogs do? They bark, right? So that's a very good mnemonic of what differentiates SLE from rheumatoid arthritis. B is for brain. Any neurologic involvement, it's SLE, right? R is for renal, K is for kidney, which is renal involvement, must be SLE. R is for rash, so photosensitivity, rash, malar rash, oral ulcers, dermatologic involvement, alopecia, must be SLE. And A is anti-nuclear antibody, which is much more common in SLE than rheumatoid arthritis. So if you remember the barking wolf, you will understand how to differentiate just based on the history between SLE and rheumatoid arthritis. So if you look at her labs, she has renal insufficiency. We do a creatinine, and her creatinine is elevated. And so by virtue of the fact that she has kidney involvement, much, much, much less likely to be rheumatoid arthritis. Much, much more likely to be SLE. By the fact that she has some hallucinations perhaps. Maybe it's all in my head. I feel like I'm going crazy. Psychosis can be a manifestation of SLE. Psychosis can be a manifestation of SLE. That in and of itself makes the diagnosis of rheumatoid arthritis much less likely. So when you're sitting on the step 3 and you're asking yourself, oh my gosh, somebody has a symmetrical proximal arthropathy, and I don't know if it's rheumatoid arthritis, and I don't know if it's SLE, think about the brain, think about the anti-nuclear antibody, think about a rash, and think about the kidney. All right? And if you find these things, you can feel fairly confident that you're dealing with systemic lupus, and you're not dealing with rheumatoid arthritis. Now, rheumatoid arthritis can give you pulmonary involvement. Rheumatoid arthritis can give you anemia of chronic disease. All of the other signs or manifestations of SLE are not really specific for SLE. But brain involvement, anti-nuclear antibody, rash or dermatologic manifestations, kidney involvement or renal insufficiency are fairly specific. Now, we say that in SLE, the involvement is much more systemic. It's more of a systemic disease. The arthritis is not so prominent. And in rheumatoid arthritis, the arthritis is much more prominent, and the systemic manifestations are a lot less prominent. And you see that in the manifestations of systemic disease and SLE. Now, what are other manifestations of SLE in the systemic manifestations of SLE? There's basically 11 criteria. 11 criteria for the diagnosis of SLE. Now, if you get 4 out of the 11, you make the diagnosis. But I will tell you, you can make the diagnosis even without 4, because those criteria were basically designed to include or exclude patients in studies about treatment for SLE. So what are the 11 manifestations? Hematologic manifestations. Most commonly, anemia, leukopenia, thrombocytopenia, false positive tests of false positive syphilis, RPR, and so on, VDRL. Okay? Anti-nuclear antibody is also one of the criteria. Immunologic phenomenon like false positive VDRL, renal involvement, neurologic involvement like psychosis, focal neurologic deficit, discoid lupus or discoid ulcers, oral ulcers, photosensitivity, anti-double-stranded DNA, serositis. These are all manifestations of lupus. So if you get 4 out of the 11, you've made the diagnosis. Now, how do we treat lupus? If I would ask you on the board, a 35-year-old female comes in with rash and arthritis, positive ANA, positive double-stranded DNA, what medication would you give that patient? Arthritis and rash. Arthritis and rash. What would you give that patient? Okay, you give NSAIDs initially, and for the rash you give corticosteroid cream. But if I wanted to give one medication, oral medication, for both the arthritis and the rash, what would I give? Wrong, not steroids. Anti-malarials. So we would give hydroxychloroquine. So for rash and arthritis, the answer is hydroxychloroquine. For rash and arthritis, the answer is hydroxychloroquine. However, for more serious systemic manifestations of lupus, that is when you give the steroids. So if they have a severe hemolytic anemia, if they have CNS lupus, then for more severe systemic disease is when you give the steroids. So, renal failure, renal insufficiency. Now, do you treat lupus nephritis without getting a kidney biopsy? No. You don't subject a patient to cyclophosphamide treatment without getting a kidney biopsy. Because you have to stage the renal involvement. And what is usually the kidney syndrome or the renal syndrome that patients with lupus get? They get nephrotic syndrome. All right. So in summary, lupus is differentiated from rheumatoid arthritis by its extra-articular manifestations. CNS involvement, anti-nuclear antibody, rash, and renal involvement or kidney involvement differentiates lupus from rheumatoid arthritis. Rash and arthritis in lupus is treated with hydroxychloroquine. Steroids is reserved for more serious systemic manifestations like anemia, CNS vasculitis. You must get a kidney biopsy before you treat patients for lupus nephritis to stage the lupus nephritis. And you treat the lupus nephritis with pulse cyclophosphamide because the side effects are much less than the daily dosing. All right, let's go on to the next case. Let's see the pictures. Okay. So this is a picture of malar rash. Okay. You see it's over the bridge of the nose, and this is what gave the disease its name. This is actually a rash with lupus. This is a manifestation of cutaneous lupus. Now this you can't see that well, but this is discoid lupus here. And we'll go on to the case 4. Well, just one quick question. Drug-induced lupus. What kind of drugs cause lupus? Hydralazine, procainamide, and INH. Zerpine also. Okay? Now, how do you differentiate between drug-induced lupus and systemic lupus? Antihistone antibodies. Okay? Antihistone antibodies, and the systemic manifestations are not as severe. And usually when you take the drug away, the lupus will resolve. Okay, let's go on. A 30-year-old African-American woman comes to the office complaining of swollen hands for a couple of months. She also complains of discoloration of the hands, bluish-red fingertips in cold weather, and some difficulty swallowing at times. She has no other symptoms and no other past medical history. Her temperature is 37 degrees, blood pressure is 110/90, pulse is 82. Raynaud phenomenon is present. Skin over the fingers is thickened, and the skin over the face and the forehead is shiny and without wrinkles. Lung examination shows good air entry. The heart examination shows an increased S2, but is otherwise normal. The remainder of the physical exam is within normal limits. So what is the most likely diagnosis here? Okay, scleroderma. Okay? Now in scleroderma we differentiate between diffuse scleroderma and limited scleroderma. Diffuse scleroderma is a systemic disease of unknown etiology where there is hyperplasia or hyperactivity of the fibrous tissue, and the patient basically fills up all of his organs and all of his subcutaneous tissue with fibrosis, which is why the skin becomes stretched, which is why the patient loses the wrinkles on the face, and which is why they die, because they get renal involvement, cardiac involvement, GI involvement, and pulmonary involvement as well. So it's a systemic disease, and the prognosis is horrible. And how do we treat systemic sclerosis? Supportive. There's no real evidence that steroids or anything else actually helps. So the prognosis is very, very, very poor. Now, limited scleroderma, otherwise known as what? CREST syndrome. CREST stands for calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasias. Okay? That's limited scleroderma. Limited scleroderma. Now, how on physical exam can you tell the difference between diffuse and limited scleroderma? It's a tough one. What? Renal, but I'm asking physical exam. Before you get to the creatinine, what would you do? How do you tell the difference? Not really. On physical exam, looking at the skin, how can you tell the difference? Exactly. In limited scleroderma, the swelling is limited to the extremities. When you have scleroderma actually involving the trunk and the proximal areas of the body, more likely to be systemic. More likely to be systemic. When are you more likely to get pulmonary involvement? In diffuse or limited? Limited, right? And what is the significance of this increased S2? Pulmonary hypertension with an enhanced pulmonic component to the second heart sound. All right? So that's a little clue. That's a little clue that there may be some pulmonary involvement as well. All right? So just on physical exam, you can have an idea whether you're dealing with diffuse or limited scleroderma. Whether you're dealing with diffuse or limited scleroderma. Now, what's the difference between Raynaud's phenomenon and Raynaud's disease? What's the difference? What's the difference between Raynaud's phenomenon and Raynaud's disease? What's the difference? What's the difference? Well, they both, clinically what happens in Raynaud's? They have an episode of it's hyperreactivity of the vasculature, right? So they have an episode of pallor when they go out in the cold. They get vasospasm, their hands become very, very pallid, and they get bluish fingertips. They may even get ulcers. And then they get sort of this the stage of rubor where the vasculature opens up and the perfusion gets better. Right? That's Raynaud's phenomenon. Now, what's the difference between Raynaud's phenomenon and Raynaud's disease? Well, Raynaud's phenomenon can occur as part of a disease, meaning patients with SLE can have Raynaud's. Patients with rheumatoid arthritis can have Raynaud's. Patients with scleroderma can have Raynaud's. Patients with mixed connective tissue disease can also have Raynaud's phenomenon. And when it occurs in the context of another condition, when it occurs in the context of another connective tissue disease, it's a phenomenon. When it occurs independent of any other connective tissue disease, it is Raynaud's disease. All right? So when we talk about Raynaud's phenomenon, if it happens with SLE, it's a phenomenon. If it happens with rheumatoid arthritis, it's a phenomenon. If it happens with scleroderma, it's a phenomenon. But if it happens on its own, it's a disease. And how do we treat Raynaud's disease or phenomenon? Okay, well, which calcium channel blocker in particular? Nifedipine. All right? So, you tell the patient to avoid cold. They shouldn't go out in the cold. They should keep their hands warm. And you can give them nifedipine. All right, let's go on to some pictures. Just a quick question. In renal crisis, in scleroderma-induced renal crisis, hypertension, renal failure, what is the first antihypertensive medication you would give them? An ACE inhibitor. Now, to make the diagnosis, what is the specific antibody to make the diagnosis of diffuse scleroderma? Anti-STL70. And what is the specific antibody to make the diagnosis of CREST syndrome? Anti-centromere antibody. So, this is the pallor stage. Vasoconstriction. It doesn't look like it's that pale, but we'll get to the next one. And then this is the non-pallor stage. So you see the difference, right? This is vasoconstriction, Raynaud's phenomenon, with vasodilatation. The treatment, again, is nifedipine. Now you see here particular findings here. You see how the head is, the forehead is very smooth and shiny. Okay? This is scleroderma. And here you can see the arm a little bit better. Sort of this puffiness and the swelling of the hands. Puffiness and swelling of the hands, consistent with scleroderma. What's this? Aha. Calcinosis. Okay, very good. So you see the calcification, not with the bone. It's calcification here, calcification here, calcification here. This is calcinosis as a manifestation of the CREST syndrome. You can't see it very well here, but here is a calcium nodule and calcinosis in CREST syndrome. All right, let's take a break and we'll come back.